Welcome to this video on failed airway management. I am Dr. Nasser Hassan, an emergency medicine consultant and medical educator, and I will be guiding you through this case-based discussion. In this video, we will focus on three key objectives: anticipating airway difficulty, applying a standardized algorithmic approach, specifically the Difficult Airway Society guidelines, and executing the procedural steps for front-of-neck access during a crisis. Consider this 65-year-old male with severe pneumonia and septic shock. While his anatomy appears normal, he presents with a profound physiological difficult airway. The primary danger here is not the intubation itself, but avoiding cardiovascular collapse during the transition. For such patients, prioritize hemodynamic resuscitation before attempting intubation. Avoid standard masks, which are often insufficient for shunt physiology, and consider delayed sequence intubation to facilitate non-invasive ventilation or high-flow nasal cannula. Now consider an unanticipated failed airway: a 45-year-old female with trauma, massive hemorrhage, and an expanding neck hematoma. After failed attempts at intubation and ventilation, she is in a confirmed CICO crisis, mandating immediate surgical intervention. The Difficult Airway Society guidelines provide a clear framework for crisis management. The algorithm moves from Plan A, maximizing first-pass success, to Plans B and C, involving supraglottic devices and face mask ventilation, before reaching Plan D, emergency front-of-neck access. For Plan A, prioritize optimal positioning and neuromuscular blockade. If you must move to Plan B, declare the failure clearly and transition to a second-generation supraglottic device, which can serve as a vital bridge to oxygenation. If Plans A through C fail, move to Plan D. Overcoming the cognitive barrier to perform surgical rescue is critical. The team leader must explicitly declare the situation as a CICO scenario and proceed to surgical cricothyroidotomy without hesitation. The scalpel finger bougie technique is the recommended standard for emergency front-of-neck access. The steps are straightforward. Identify the anatomy, make an incision, dilate with your finger, insert a bougie, and pass a cuffed endotracheal tube. The vortex approach is a valuable tool for managing cognitive load during these crises. By visualizing airway management as a funnel, it helps teams recognize when lifelines are exhausted, prompting an immediate transition to surgical rescue when necessary. Pediatric cases like this 3-year-old with signs of epiglottitis require extreme caution. Do not agitate the child or perform invasive exams in the emergency department, as this may precipitate complete airway obstruction. Immediately involve your ENT and anesthesia teams. Remember that pediatric airways are anatomically and physiologically distinct. Factors like a large occiput, higher metabolic rate, and smaller functional residual capacity mean there is almost zero margin for error during intubation. To summarize for residents, anticipate difficulties early, standardize your approach with checklists, call for help, and limit intubation attempts. Most importantly, mentally rehearse these procedures so that you are prepared before a crisis hits. We have covered a wide range of critical concepts today. I encourage you to review the referenced guidelines and continue practicing these techniques at simulation stations. Thank you for your attention to this vital topic.